postgraduates and interns. It is my great honor to welcome you all on this occasion of pulmonary medicine with the NSS unit. World Tuberculosis Day is observed every year on March 24th to raise awareness about tuberculosis and to reinforce our commitment towards its prevention, early diagnosis and effective management. As healthcare professionals, it is our collective responsibility. Principal Major Bhimeshwar Sir, Medical Superintendent Dr. Anil Kumar Sir, and our Vice Principal Dr. Shrikant Sir, and Head of the Department Dr. Banureka Ma'am onto the dais and grace the occasion.
Madam, sir, ఒకసారి నుంచోండి కొద్ది ముందు రండి సార్ కొద్ది ముందు. ఓకే, రెడీ సార్? సార్ ఓకే.
Superintendent Dr. Anil Kumar, Vice Principal Dr. Shrikant, Dr. Sujata, Professor of Respiratory Medicine, other faculty of the Respiratory Medicine, and postgraduates of the first year. Good morning to all of you. March 24th marks the World Tuberculosis Day. And every year it has been a custom for the Department of Respiratory Medicine to observe this March 24th every year, and a lot of things, I mean, you people are not aware of what happened last year and all. Every year the awareness about tuberculosis is spread by the department in a very big way, and same this year as well. So the Department of Respiratory Medicine is doing immense service for the awareness about tuberculosis, because we are all not aware what tuberculosis used to cause during those times, maybe in the 1920s, 30s and all. If a person, the life expectancy was not more than 40 years those days, and most of the people used to die because of tuberculosis. In fact, one in every seven those years used to die of tuberculosis. And it was in 1882, March 24th, when Robert Koch discovered the Mycobacterium tuberculosis, and then there has been a radical change in treatment or diagnosis or whatever about tuberculosis, awareness about tuberculosis. And that is what is being spread throughout the world about tuberculosis. Even we in India, in the year 2026, this year, TB Mukt Bharat, this has been the slogan, and 100 days of campaign about tuberculosis awareness and how to eradicate the entire thing. That's one thing, yes. And then the motto for 2026 is, yes, we can eradicate tuberculosis by all the countries, powered by all the people. This is the motto for this year, and it's a wonderful initiative taken by the Department of Respiratory Medicine. I congratulate Dr. Banureka and the entire team And thank you for giving me this opportunity. Thank you.
Director sir, Superintendent sir and Vice Principal, my dear colleagues and dear students. Very warm welcome to you all for this tuberculosis sensitization program on the eve of World TB Day, that is March 24. Every year, March 24, it is observed as World TB Day in the honor of Dr. Robert Koch, who announced the discovery of a causative organism for tuberculosis, that is Mycobacterium tuberculosis. And he also postulated the mechanism for the causative disease tuberculosis, the formation of granuloma, that we call it as Koch's postulates. He announced it is in the year 1882 on March 24. Exactly 100 years later, that is from 1982 March 24 onwards, it is observed in the honor of Robert Koch. It is observed as World TB Day from then onwards every year with a slogan mainly to create awareness about this disease and also to accelerate the fight against this deadliest disease. So, and this year theme, yes, we can end TB, led by countries, powered by people. So means we all together, all the countries, all the people together fight against and to end TB. That is the slogan for this year. So why we are talking about tuberculosis so immensely? Because tuberculosis is not a new disease. It is a very ancient disease known to mankind long back from 3000 BC. But even still today, it is the topmost infectious killer disease in the world, not in India. In the world, if you name it any infectious disease, it is the single most infectious top killer diseases in the world, and India holds more than 1/4 of the tuberculosis burden of the globe. Means we are harboring more than 1/4 of the tuberculosis cases in the world. India is highest endemic country for tuberculosis. So that's why we are fighting against this. And recently, India is striving very hard to fight against this TB with a slogan to end TB by 2025 by the program, through a National Tuberculosis Elimination Program from the year 2020. Before we call it as Revised National Tuberculosis Program, and now we are naming it as National Tuberculosis Elimination Program. We are setting a goal to eliminate TB by 2025, but we have already crossed that. But we couldn't able to reach our targets. But India is we are fighting against, we have achieved some milestones through our program. So if you see the statistics, the incidence of tuberculosis used to be decreased from 237 per 1 lakh cases in 2015 to 195 per 1 lakh cases in 2023, a reduction in rate of incidence of 17.7%. And mortality also come down from 28 per 1 lakh deaths in 2015 to 22 per 1 lakh deaths in 2023, with a 21% reduction in the mortality rate. And India also have notified highest tuberculosis cases in the year 2024 of more than 26 lakhs, with highest TB notification rates. So India is progressing. It is striving very hard to control the tuberculosis through the program. But even today, we are the leading in tuberculosis cases, even tuberculosis and diabetes, and tuberculosis and HIV, and even drug resistant. So we are the leading in the numbers, if you see in the world. So again, we are setting a goal to eliminate TB by 2030, and India is marching forward to that. And to strengthen our program, medical colleges play a crucial role. Like medical colleges, crucial role in the diagnosing complex tuberculosis cases and also in advanced research, so that to understand the disease and to take the control measures. So in this context, we are conducting this sensitization program to give awareness of the tuberculosis program to all the first year postgraduates particularly, because they have to know what are the facilities available in our hospital, what are the diagnostics and treatment facilities available. So I think this program will be helpful to you in your clinical work, and I request you all to actively participate and interact. Thank you. I thank Principal Sir for giving us this opportunity. Thank you, sir.
Valuable words. I now request Dr. Jansi ma'am, our assistant professor, to kindly propose the vote of thanks.
Good morning, one and all. Honorable Director, Dr. C. Rao sir, respected Superintendent, Dr. Anil sir, Principal Major Bhimeshwar Rao sir, and Vice Principal Dr. Srikanth sir, and our beloved HOD Dr. Bhamreka ma'am, faculty and my dear friends. It's my privilege to propose vote of thanks on this occasion. I, Dr. Jansi, on behalf of Department of Pulmonary Medicine, extend a hearty vote of thanks to all the honorable invitees who blessed us with their presence and took our valuable time. I would like to express my special thanks to NSS unit of Pinnamaneni Dr. Bhimeshwar Rao sir and Dr. Praneeth for their cooperation. I would like to thank our distinguished speakers, Dr. Sirisha ma'am and Dr. Maunika ma'am, who are going to make this program interesting and meaningful. I would like to thank our beloved HOD, Dr. Bhamreka ma'am, for her moral support and guidance. I would like to extend my special thanks to all the PGs and interns for their active participation. Last but not the least, I would like to thank audiovisual people and RTF staff for their support. Thank you.
We'll have a short tea break, and I request everyone to kindly reassemble within 10 minutes. And attendance will be given only after that, whoever stays till the end of the session.
Greetings to everyone from the Department of Pulmonary Medicine. Next few minutes today we will be discussing about the program, its insights, diagnosis and treatment of tuberculosis. And please hold on with me while we will be knowing some interesting facts in the form of questions where you will give me the answers while we are discussing about this topic. Heinrich Hermann Robert Koch was a Jewish-born German physician and a microbiologist. On March 24th, he announced the discovery of Mycobacterium tuberculosis, which is the bacteria causing tuberculosis. It is discovered in 1882. But what happened after a century? After a century later, in 1982, only then the global community has recognized March 24th as a World TB Day, recognizing TB, which is causing epidemic all over the world. And every year, WHO gives us a theme on World TB Day. And every year, on the eve of World TB Day, we will be having a theme for tuberculosis, for motivating the countries to for its action against tuberculosis. So what is the theme for the World TB Day in the year 2025? It is, yes, we can end TB, commit, invest and deliver. So do you know the theme? Have you heard about the TB theme, World TB Day theme for the year 2026? Just now, as said before, it is, yes, we can end TB, we can end tuberculosis led by the countries and powered by the people. Why we should know about TB? The whole point of sensitization today is because TB is the most devastating health problem, single infectious agent worldwide, which is the first leading cause of death by a single infectious agent. It is not COVID-19, it is not any other disease, but the estimated number of TB deaths as per 2024 statistics is 1.08 million. It is so much impact, it has so much impact on overall the world, where a serious action and need of activities to be taken to hinder it. According to Global Tuberculosis Report 2025, this is given by WHO every year. According to the report 2025, an estimated of about 1.23 million deaths have been recorded globally all over the world. And among them, 1,50,000 is contributed among the HIV people. So this is the mortality. Then what about the incidence? Incidence of TB globally is 10.7 million all over the world. So it has a big number, so it should be hindered. It should be hindered across the world, right? So what the TB burden in India? These are the top 8 high TB burden countries. among which India holds a number of 25% of all the TB cases globally. So we, even with the high TB, high MDR and high HIV TB burden, we stand top at the list, accounting for 1/4 of all the cases. So India took it seriously and then initiated various TB programs to control the disease. According to Global TB Report 2025, the TB burden in India is given as the incidence is about 187 per lakh population and the mortality is about 21 per lakh population. But the positive side of it, due to various coverages done by NDEP, the incidence and mortality has a rapid fall than all other countries. TB incidence, there is a fall by 21%, and global and by TB mortality, the fall is big. Even there is a fall to 21 per lakh. And the treatment coverage rose from 50% to 90%. Even the success rates for tuberculosis in India increased to 90% against the global success rate of 88%. So, according to India TB Report 2024 statistics, India stands in the top with not only in the high TB burden but also in the high MDR TB and the high TB with HIV burden country. So, India took it seriously and then started various programs initially to control and then now to eliminate the disease. This is the evaluation of TB elimination program in India. Initially, in 1962, India started a program with the name National Tuberculosis Program to control the disease. And then afterwards, it is renamed as Revised National Tuberculosis Control Program in 1993, the way forward in 1993, which is popularly known as RNDCP program. The main initiatives by this program are DOT strategy, directly observed treatment short course, and stop TB strategy. What is DOTS? As all of us know, a DOTS provider will be giving the treatment and monitoring the patient all over the course so as to prevent the patient from loss to follow-up. And then now in 2020, it is renamed again as National Tuberculosis Elimination Program. What are the initiatives by this program? To end TB strategy and National Strategic Plan, which is introduced in 2017. So what is National Strategic Plan? It is the Tuberculosis Control Plan introduced in 2017 and it is aimed to achieve universal access to all the diagnostic services and treatment services provided under National TB Program. So in 2020, RNDCP was renamed as NTEP, which is National Tuberculosis Elimination Program. So what is National Strategic Plan? As already told, it ensures the quality diagnosis, the quality treatment and support universally to each and every TB patient irrespective of the cost, irrespective of the region. So what are the initiatives taken by this plan? The first thing is the TB treatment and TB diagnostic modalities. As you can see, they are provided free of cost by RNDCP program to each and every patient all over the nation. And also about 12,000 crores of budget has been allocated to control this devastating disease. And of about 500 rupees per month is being transferred to all the notified TB cases under this RNDCP program. Okay, but recently in 2025, this amount has been doubled to 1,000 rupees. It will be transferred by DBP to all the notified cases for their nutritional and vocational support. So, NDEP is planning providing the treatment at free of cost and also giving nutritional support at free of cost to all the notified TB cases. What is the target for this plan, National Strategic Plan? The target for India is to eliminate the tuberculosis by 2025. But we are not able to achieve it, but we'll see what happens. There is a global commitment to end the TB by 2020. This is a commitment taken by WHO globally. But India, what happened with India? India has already started in 2018 itself. It announced to end TB by 2025, 5 years ahead of the global target. 5 years ahead from the global target given by the WHO. but we are not able to achieve this, but we made a significant improvement in the statistics of TB burden in India. What happened is there is a steep decline in the curves of TB incidence and TB mortality. Like giving rise to incidence of TB in India has declined far away from 237 per lakh in 2015 to 187 per lakh in 2024. Then what is with the mortality? Mortality has also declined from 28 per lakh population in 2015 statistics to 21 per lakh in 2024 statistics. So even WHO has appreciated this. The positive side of NDEP being coverage is WHO announced a health milestone that India has recorded one of the sharpest declines than any other countries in TB incidence, nearly doubling the pace of reduction rate when compared to worldwide. You can see there is a rapid decline of 21% when comparative to global decline, an average of about 12%. This is the positive side of the coverage, but still we are far away from achieving the goal of eliminating the TB. So what are the objectives of NDEP? The objectives of NDEP are 5, and they are achieving 90% notification for all the TB cases without missing any of the case, achieving 90% success rate for all the new TB cases and 85% for the retreatment cases, and to give successful outcomes even for the drug-resistant TB cases, and also to decrease the morbidity and mortality associated with HIV-associated TB, tuberculosis, and to improve the outcomes even for the TB care in the private sector. For achieving these objectives, the NDEP has given 4 strategic pillars for the achieving the TB elimination as planned by NSP. The 4 strategic pillars of NSP are to detect, to treat, to prevent, and to build. What is with the detect? To detect all the cases nationwide, all over the country, even including the drug-resistant TB cases, with the help of diagnostic and treatment facilities which are provided universally all over the country at free of cost services. To treat all the patients, all the notified patients with quality assured drugs, and also providing the nutritional support as mentioned earlier. Then what with the prevent? To prevent the TB emergence, to cause decline in the TB incidence. Even the NDEP has started TB preventive therapy in all the high-risk patients, and also the TB vaccination programs. Then what is the build? To build and to strengthen the existing health systems to increase the private sector engagement. Okay, now we'll have an interesting question about tuberculosis. Guess who among them are infected, famous persons who are infected with tuberculosis? Kakal, anyone knows him? Yes, he's Srinivasan Ramanujan, famous Indian mathematician. No need of introduction. Who is he? He's famous India. Then who is she? She is Kamala Nehru, wife of Jawaharlal Nehru. Even he is a Pakistan leader, famous person, Jinnah. So any guesses? So just anyone can come up with the answer? Okay, we'll have some voting session. How many of you opts for the first picture? Please raise your hands. Please, I need to interact at least by raising your hands. The second option? You don't want to answer, but still you have to answer. But Kamala Nehru? Yes, many of them are with Kamala Nehru. That's good. For Jinnah? Actually, all of them are infected. Yeah, I didn't say only one of them are infected. Okay, it's a little bit tricky. Next, who are the risky population for contracting the tuberculosis disease? All the malnourished people, all the HIV positive people, all the smokers and alcoholics, and even all the diabetic people are at risk of contracting TB. It's not only them that can have TB. Even any one of us can contract tuberculosis. But these people have more vulnerability of contracting tuberculosis. Like diabetics, they have 2 to 3-fold increase in the contracting the rate of tuberculosis. In HIV positive people, it is 6 to 8 times more. Among smokers and alcoholics, it is 10 times even more than the healthy people. But a normal healthy people also person can also contract TB. But in case of vulnerabilities, it becomes a little bit difficult to manage them. What is TB? It spreads by touch, it spreads by air. Spreads by air, or the droplets on the aerosols from the infected person can spread the infection to the others. This is an interesting fact that an untreated TB case can transmit the disease to at least 10 to 15 people in a year. So in this way, all the contacts of active disease who stays in the household of the same active TB disease person are at 10 to 16 times more vulnerable for developing the disease. So this is the diagrammatic representation of the lungs. Having first picture is healthy lungs, second picture is single cavity, third picture, in case of vulnerability, it spreads more faster. So another question, which organ is not infected with mycobacterial tuberculosis? Option A, lungs. Who want to vote for lungs? Option D, heart. Anyone with heart? No. Option C, hair. That's nice. Option D, skin. That's good. That all of you gave the correct answer. Only the organs that not get affected by tuberculosis are hair and the nails. Rest of all the organs can be infected with tuberculosis. Moving on to the diagnosis of tuberculosis, it can be segregated by microbiological diagnostics and clinical diagnostics. Microbiological diagnostics, we have the sputum microscopy, rapid molecular tests like CBNAT and TrueNAT, line probe assays, and cultures. And clinically, we can detect the cases of TB with the help of radiological investigations like X-ray, CT, and in extrapulmonary cases, we take the biopsy or FNAC samples and send them to histopathology. What are all the clinical symptoms? As all of you know already, the cough, fever, mainly intermittent fever, evening rise of temperature, night sweats, fatigue, generalized weakness, generalized body aches, restlessness, chest pain, and most importantly, loss of weight and loss of appetite are the main clinical symptoms. So moving on to microbiological investigations, the first one which is commonly and widely performed under NTEP services is sputum smear microscopy. Here, the sputum sample which is representative of the aspirate from the lung is collected. The patient is given a sputum container like this and he collects the sputum into it. And at least 2 sputum samples should be collected, one at the spot and other one is the early morning sample. So at least 10 power 4 bacilli per ml of the sputum should be there for the microscopy to come out as positive. Next question, mycobacterium tuberculosis. Is it a gram-negative or gram-positive bacilli? I'll give only 2 options here and we are running out of time. So option A, gram-negative bacilli. Who wants to vote? Gram-positive bacilli? Yes. It's not only acid fast but it is also gram-positive bacilli. As you already know, it is a very older technique, this sputum smear microscopy, and mycobacterium tuberculosis is a gram-positive bacilli because it retains the primary strain, that is carbon fusion even after decolorization with acid alcohol, and that's why the term acid fast bacilli is given to it. The first picture shows you the mycobacterium tuberculosis, the slender pin-shaped rod-like bacilli in the Jaden staining method. The second picture, you have a very shiny rod against a dark background. It is the technique done by using fluorochrome-based staining. So these are the fluorochrome-used techniques. Though sputum smear microscopy is widely used, it has a low sensitivity of 50 to 75%. But very high specificity with 95%. So this is not sufficient to be introduced into NTEP to detect all the cases. So NTEP came up with a newer techniques like CBNAT, which is cartridge-based nucleic acid amplification technique. It is also known as expert MTB and RIF test. It works with the mechanism of rapid real-time PCR and identifies the TB genome and also the gene which causes resistance to rifampicin. The technique only takes 2 hours for it to give the result, and simultaneously detects if the person is having TB and also if he is having TB, whether he is resistant to rifampicin or not. So this is the cartridge CBNAT machine, and the blue thing this side is the cartridge where the sputum sample is lodged into it and it's placed into the chamber inside, where the sample gets purified and amplified with the technique of real-time PCR for detecting the TB genome and also detecting the gene for positive rifampicin resistance. Like we can see the result on the other side. MTB detected, yes or no. Rifampicin resistant detected or not. The result will be given like this. It is also known as universal drug susceptibility testing because it is introduced nationwide in all the primary TB care units for all the patients free of cost. Even in our hospital, we are having this device which we can get the result within 2 hours of the test. The speciality is we can get the result rapidly after introducing the sample within 2 hours. So the current diagnosis is being made with universal DST technique, that is CBNAT or TrueNAT. And this is the report of the patient having whether he is having TB or having rifampicin resistant by CBNAT technique. What is the speciality of CBNAT? It detects as low as 100 bacilli in the per ml of the sample, therefore making it a very sensitive tool for TB diagnosis. If the sputum smear is positive, then the sensitivity is 99%. If the sputum smear is negative, then the sensitivity is 90%. It can be all the other extrapulmonary samples like cerebrospinal fluid, lymph node, aspirates from the joint, ascitic fluid, pleural fluid can be tested by this technique. Every sample has a sensitivity of around 70 to 80%, making it is a better device to test even extrapulmonary TB. Only the pleural fluid sensitivity is low for about 50%. We know that turnaround time is about 2 hours. The current molecular tests that are recommended by National Tuberculosis Elimination Program are Gene Expert on this side and TrueNAT on this side. Both work on the same mechanism, but NTEP using TrueNAT devices all over the nation in every TB care units because TrueNAT is Indian made, and the difference between TrueNAT and CBNAT is in TrueNAT the MTB gene is detected first, again the sample is introduced, and then the rifampicin will be detected. So this is a stepwise technique, whereas the CBNAT is the 2 steps will be done at a time. But turnaround time for both the techniques is same, that is 2 hours. What is Gene Expert Ultra? Gene Expert Ultra works on the technique same as CBNAT, but it is much more sensitive. It detects even patients with very low maxillary load like extrapulmonary TB or HIV TB, and NTEP is planning to replace CBNAT with Gene Expert Ultra, not to get any of the TB cases to be missed. The other molecular technique is NPA, which is line probe assay. It works on the mechanism of same by amplification by PCR and reverse hybridization techniques. And line probe assay is also there under NTEP services, where it detects the drug resistant to the present ADT or antitubercular drugs. First line LPA detects resistance to first line first line drugs, HRZD. Second line LPA detects resistance to second line drugs like fluoroquinolones and injectable aminoglycosides. This is there at free of cost, like making even detection of drug resistant TB is done at free of cost for all the TB patients. Apart from molecular diagnostic test, we also have a liquid culture test which is there under NTEP services, which also gives us test result within 1 week. This is the liquid culture, famously known as the liquid culture technique, famously known as MGIT or Bactec medium. The various turnaround times for various TB tests which are there under NDEP are the liquid culture, which gives us the result within 10 days for smeared positive samples. We have to wait up to 6 weeks if the smears are negative. And then the line probe assay gives us the turnaround time is 1 to 3 days. CBNAT and TrueNAT, the turnaround time is 2 hours. Apart from these tests under NDEP, there are other tests which can be done. For extrapulmonary TB cases, we can take the biopsy FNAC and subject it for histopathology. Clinically, we can detect the cases with the help of imaging like chest X-ray, CT, and also biomarkers like lipoarabinomannan test in the urine can also be taken for detection, but these are not specific and diagnostic of tuberculosis. When we run through these imaging studies, the typical radiographic patterns for tuberculosis are, in this X-ray we can see in the right upper zone, there is some amount of nodular opacities with some amount of fibrosis which is typical of tuberculosis. This is the second one is X-ray of miliary TB, where we have nodules all over the randomly all in both sides of the lungs. The third X-ray is showing us the large cavities which predominantly situated in the bilateral upper zones, which is the diagnostic of post-primary tuberculosis. So, what is the approach actually? When you come across a patient of presumptive pulmonary TB, what is presumptive pulmonary TB? It is a person having the symptoms cough or fever of more than 2 weeks duration and with significant appetite loss and weight loss, or having hemoptysis, any other abnormality in the chest X-ray, he is labeled as a presumptive pulmonary TB patient. Then how to approach in this, how to make a diagnosis? Presumptive TB patients are subjected to CBNAT or RT-PCR technique, and then they can be labeled as, if they have the TB as a diagnosis, they can be labeled as rifampicin resistance or rifampicin sensitive. If there is rifampicin sensitivity, they can be started on drug sensitive TB treatment. If they are rifampicin resistant, then we have different categories under drug resistant TB. The common one is MDR TB, which is defined as TB that is resistant to isoniazid and rifampicin without resistance to other drugs. If the patient is known to have resistance to isoniazid and rifampicin, then they can be started on MDR TB regimen. Moving on to pediatric TB. Pediatric TB is a bit more difficult to diagnose because the classical signs and symptoms will not be there. Even those populations cannot produce the sputum sample to test them for CBNAT. Who is presumptive pediatric TB? They are the patients having cough and fever of more than 2 weeks duration, having definitive weight loss or failure to thrive, which is an important symptom in pediatric TB patients, and history of contact or exposure to pulmonary TB patients in the household in the last 2 years. In pediatric TB patients, the approach will be little bit different. They are investigated with the help of chest X-ray, and then if they can produce the sputum sample or the gastric aspirate is collected, they can be sent for CBNAT, and if they are detected to have TB, straight away started on treatment. But if they are having negative for CBNAT and they have X-ray is not suggestive of TB, we have to check for peripheral, any enlargement of lymph nodes peripherally, and FNAC should be done, and those samples can be sent for CBNAT and they can be started on the treatment. Any other diagnosis unlikely or no other diagnosis likely apart from TB, they can be labeled as clinically diagnosed probable case of tuberculosis and treatment can be started. Coming to the treatment of drug sensitive TB is in case of new or previously TB cases, the treatment is the same. 2 phases are there. One is intensive phase, we give it for first 2 months. Continuation phase is given for next 4 months. First 2 months, they are being treated with the drugs like HRZD. H is isoniazid, R is rifampicin, Z is pyrazinamide, and E is ethambutol. And in continuation phase, we omit Z and we give 4-HRD. Previously, it is intermittent regimen, but nowadays under RNDCP, it has been changed to daily regimen, where the patients will be taking these tablets daily. The drug or the treatment is given in the form of FDC, that is fixed drug combination. Each tablet will be having fixed doses of H, R, Z and D, and they are given according to their weight bands. For example, if the patient comes in the weight category of 25 to 35, they are given FDCs of 2 tablets. 35 to 50, they are given FDCs of 3 tablets. Okay, and so on. This is the weight band table for treating pediatric TB patients. The total course will be for 6 months, intensive phase 2 months, and continuation phase for 4 months. So what are the do's and don'ts while taking medicine? They should be counseled that they should not continue if they are having habits of smoking or alcohol. They should be omitted, and only then they can be treated effectively. And then for the next initial 3 to 4 weeks, as the person will be very much infective to contract to spread the disease to the other persons, for the initial 3 to 4 weeks, the patient should be asked for isolation at home. After 1 month, the infectivity rate that the person can spread to others will decrease, and then they can go on like that. How we follow these patients? They should be followed every month clinically. As per the lab investigations, the sputum smear microscopy is done only at the end of the intensive phase and at the end of the treatment. If the sputum smear comes to be negative, and then only we call them as treatment cure for tuberculosis. CBNAT should not be used for follow-up because CBNAT gives us some false results, because it can even take the dead bacilli and give the positive results. What is the treatment monitoring in children? As they are difficult to monitor, we assess them clinically whether they are putting weight and all, and then they are continued throughout the course of the treatment. Every patient should be long-term follow-up, well, like at 6 months, 12 months, 1.5 years, and 2 years. The clinically they can be monitored, and lab investigations can be done only whenever there is a doubt. What are the side effects of ATD? All the known side effects for all the general drugs like nausea, vomiting, loss of appetite, some amount of giddiness is there. Even some patients will come up with rashes, which are general hypersensitivity reaction to the drugs. They subside as we do some antihistamines, and no need of stopping the treatment. And with individual drugs, when we come, isoniazid has a major side effect of peripheral neuropathy. Therefore, we have to give, whenever you isoniazid to high risk group, we have to give them nerve growth vitamins like the pyridoxine. For rifampicin, the major known side effect is orange colored urine. Simple reassurance will do in these cases. Pyrazinamide, the patients will come up with arthralgias or joint pains because of the deposition of uric acid crystals, mainly in the grade 2. Drugs which can reduce the uric acid can be given along with the TB treatment. Coming to ethambutol, it can cause red-green color blindness and also optic neuritis, that is inflammation of the optic nerve. If the patient is having these side effects, then we should omit ethambutol from the treatment regimen. The other known side effects are hepatotoxicity and renal failure. Many of the TB drugs like isoniazid, rifampicin and pyrazinamide are toxic to the liver and to the kidney, and then treatment adjustments can be done in those patients. If you have side effects, do not stop the medication. Please consult the doctor. Because if we stop the medication, that will lead them to having drug-resistant tuberculosis and treatment relapses. The Mantoux test is not diagnostic of active tuberculosis because it can also give positive results in case of previously infected patients and patients with old BCG immune status. Detecting latent TB, interferon gamma assays are also there, like quantiferon TB gold and TB spot test, where we measure and see the amount of interferon gamma released from T lymphocytes of these patients. And those are diagnostic only for latent TB but not for the active disease. The last part, prevention. Prevention of tuberculosis can be done by vaccinations and TB preventive therapy. What is TB preventive therapy? TB preventive therapy is the latest measure taken by the NTEP for where the high-risk people are screened for tuberculosis and they have more vulnerability of contracting the disease, so they are given a far more ahead before contracting the disease, so that the amount of active TB intensity in them can be reduced. So who are all the patients that can be given for TB preventive therapy? Like people living with HIV, all the patients on immunosuppressive drugs, silicosis patients, dialysis and renal transplant patients, the infants who are having TB contact, and all the household contacts of less than 5 years of active TB case. The currently used regimens that can be given in the path of TB treatment are 6 months daily isoniazid, 3 months weekly isoniazid along with rifampicin, 1 month daily isoniazid and rifampicin. Before giving the therapy, active TB should be ruled out and strict adherence to the treatment should be maintained to prevent them to go to drug-resistant TB. NICSHI is an integrated computerized system that is provided by our TB programs for the TB care in India. All the cases of TB should be notified into this system, even by the private practitioners and also by the DOT service providers. So what is this is a newer measure taken by NTEP. Even not only the infants, newborns, even the adults who are at risk can be given this BCG revaccination for them to lower the risk of contracting the TB disease in the future. This is not yet proven but is still under study. Last question. Can we eliminate TB from India or from the world? Really? Is it possible for us? Yes? How many of you know that? No? You don't have idea about it? Yes or no? Yes. Okay. Even we don't. Actually, what are the flaws hindering us from achieving this goal? So many patients are having loss to follow, is having the symptomatic improvement within 2 months, and they're getting lost to follow, difficult to track them, and the emergence of drug-resistant TB cases, which is more difficult than managing drug-sensitive TB, or the socio and economic factors like malnutrition, poverty, managing the comorbidities like diabetes. Because of all these flaws, we didn't eliminate TB by now. Then what is the role of us? Role of us as part for us India to get the TB eliminated in the near future. As all of you are in different specialties, please when you encounter with a case of extrapulmonary TB in your respective specialties, have a high clinical suspicion, subject them to different diagnostic facilities available on NTEP, or also you can start them on empirical AKT. Before starting them, please put them only on the standardized regimens with under NTEP program. Do not give them half of regimens having 1 or 2 drugs, which can cause really harm to them actually. And whenever you go to your private practice, you should be notifying all the TB cases to come across under NICSHI code. Maybe by addressing all these flaws, maybe TB can be really eliminated from all the country, at least by 2030, 40 or 50 like that, whenever it is possible. Thank you.
Session. And now I request Dr. Sirisha, Associate Professor, to deliver her talk on From Nodes to Neurons, the Multi-System Spectrum of Extrapulmonary Tuberculosis.
At the back, am I audible? Okay. Hello all. First, I want to see the first year postgraduates. Can you please raise your hands? I just want to know where you're sitting. Okay, that's a very good number. So I see full of fresh faces who survived all the sleepless nights, all the entrance examinations, but only to get into something very intense, your 3-year residency program. Hearty congratulations and all the very best on this phase of your career. Okay, Dr. Monica, my colleague, has already elaborately discussed on pulmonary tuberculosis, which is the key for any tuberculosis discussion. So building on this idea, I would like to brush on the other side of the coin, that is extrapulmonary tuberculosis. I hope this will address all the departments and find some sense for getting into this topic. Okay, so pulmonary tuberculosis is the major concern, right? So why are we even talking about extrapulmonary tuberculosis? So here the numbers and stats are very significant. It almost contributes to around 15 to 24% of all the notified TB cases, which is not a small number. And most importantly, you need to know that around 50% of all the TB cases in HIV positive, diabetes, chronic kidney disease and immunosuppressive patients accounts to the extrapulmonary tuberculosis. So important thing is, in extrapulmonary tuberculosis, we are missing out on the diagnosis. Diagnostic delay is the hurdle because TB is the great masquerader. So we are already running out of time, and in the coming, we only have 20 minutes to go. In the next 20 minutes, hello on the back, everyone, just 20 minutes. So what to expect in the next 20 minutes? I will be talking about the common extrapulmonary sites, classical signs and symptoms, diagnosis, and this when to suspect only for the postgraduates. I want you from the respective departments to just at least listen to that slide, and treatment, it's already covered. I'll just emphasize only when there is prolongation in the duration. And at the last, I have an MCQ post-test for you. Just 10 MCQs. I hope you will answer correctly. Okay, what are the common forms of extrapulmonary tuberculosis? We have lymph node tuberculosis, pleural, CNS, skeletal, abdominal, genitourinary, pericardial, cutaneous, ocular, ENT. So as ma'am already told that we don't have a single organ except hair and nails. Rest of all the body is involved. So this is just a pictorial description. So moving on to TB lymph node. This is the most common form of extrapulmonary tuberculosis. Here many systems are involved. You can see the most common site is cervical lymph nodes, and usually the first line of investigation here is FNAC, fine needle aspiration cytology, and the gold standard is always for any lymph node it's excision biopsy and sending the sample for histopathological examination. So if you talk about a case scenario, it is like, it's a very simple description, like an young female presenting with neck swelling, a painless cervical swelling since 3 months with low-grade fever, weight loss, and on examination, if there are matted multiple cervical lymph nodes, fluctuation positive. So this is important. So I'm talking about the cervical lymph nodes, and to the other departments like general surgery. How many of you are general surgery here? Okay. So abdominal tuberculosis. So abdominal tuberculosis is also a very important entity where patients present with dull or colicky abdominal pain. And most important thing is, throughout all this extrapulmonary tuberculosis, I will be talking about the constitutional symptoms, which was already discussed. So every patient, we need to look into the constitutional symptoms, which are weight loss, loss of appetite, night sweats, fever, etc. So these are common in everything. So cervical, abdominal and mediastinal, again for the pulmonology, mediastinal lymphadenopathy or hilar lymphadenopathy, which you can see as an X-ray, hilar widening on the chest X-ray. So treatment, it is the same, 6 months HRCD plus HRE. So moving on to the pleural tuberculosis, which is the second most common form of extrapulmonary. So pulmonology postgraduates. So this is the most common cause of pleural effusion. Whenever pleural effusion presents in the endemic areas, we can actually think or consider tuberculosis as a primary cause. And so if we look at a 40-year-old male presenting with fever, dry cough, pleuritic chest pain, breathlessness, always you have to have tuberculosis in your differential diagnosis. So pleural fluid analysis. So when you do a pleural tap, this is the thing, exudative, lymphocytic predominant, this is, I only put an image in the pulmonology, so rest all due to lack of time I will skip. So this is a classical X-ray showing right pleural effusion and adenosine deaminase. So ADA is the thing we'll do which is significant in case of pleural effusion. We'll do a pleural tap and we'll send ADA. Greater than 70 it is high likely to be pleural TB, and 40 to 70 indeterminate, less than 40 low likely to be pleural TB. And then pleural fluid you can also send for CB-NAT, and you can do a microscopy and also cultures. And at the last, if you want to go for a definitive thing, you will go for thoracoscopic pleural biopsy and HP. So when to suspect, it's the constitutional symptoms, dry cough, chest pain, progressive breathlessness, and with clinical examination findings of pleural effusion. So treatment, it's 2 + 4, again HRJD plus HRE. So CNS tuberculosis. So infection caused by mycobacterium involving the meninges, brain or spinal cord. Most common is meningitis, and CSF analysis is very important here. Appearance is cloudy, and here you will have lymphocytic pleocytosis. It's the same anywhere, it is lymphocytic predominance and increased proteins. So if you look at a case, 30-year-old patient presenting with headache, vomitings, fever, seizures, with all this like especially subacute onset. When you look at presumptive TBM, that is TB meningitis, any patient who is presenting with clinical features of meningitis in the form of fever, headache, neck rigidity and vomiting, or with or without altered sensorium and associated focal neurological deficits for a period of 5 days or more. You should always think in line of tuberculosis for the general medicine residents. And diagnosis, CSF analysis, and the typical radiographic findings, especially in the MRI, and for every extrapulmonary tuberculosis or pulmonary tuberculosis, it's mandatory you need to do the HIV testing as per the Index TB guidelines. And investigations, as it was already done, lumbar puncture and CSF analysis. CSF ADA greater than 10 units, its sensitivity is more than 90%. So biopsy from any other lesion if there is a tuberculoma. Constitutional symptoms, subacute onset neurological symptoms like headache, vomiting, altered sensorium, and features of meningitis, neck stiffness, photophobia, cranial nerve palsy, seizures, focal neurological deficits like hemiparesis, cranial nerve palsy, aphasia, and this is very important, unexplained seizures with any ring enhancing lesion on imaging. This is a classical description for tuberculoma. Treatment, 2 months of HRJD, continuation phase. Usually here there is prolongation for CNS tuberculosis. 9 months, it can be extended up to 12 months. Moving on to skeletal tuberculosis. So infection of the bones and joints caused by Mycobacterium tuberculosis. Spine is the most common site involved, which is Pott's disease. It can present with back pain, paraspinal muscle spasm, vertebral body destruction, and deformity, gibbous, and kyphosis, neurological deficits if spinal cord compression occurs. And for the ortho residents, it's always MRI is the gold standard. So spine, and also this also presents with arthritis. Hip and knee are the most common sites. A 50-year-old patient presenting with chronic back pain since 3 months, progressive weakness since 3 months, and if MRI spine shows vertebral destruction with paravertebral abscess, always it's very classical for tuberculosis. So diagnosis, as I told you, MRI 100% sensitivity, specificity also 80% it carries, and gene expert 82%, and definitive is always HPE. So persistent bone or joint pain, gradually progressive swelling, restricted movements, constitutional symptoms, chronic back pain, or if they are presenting with delayed, like if there is a delayed presentation, like weakness in the limbs, paraplegia, etc., cold abscess. So arthritis especially affecting the hip and knee. Always think of tuberculosis. So treatment is 2 plus 10. Actually skeletal tuberculosis, you have an extension in the treatment. Usually it is 6, here you will give for 2 plus 10, that is 12 months. It can be extendable up to 18 months on case by case basis as per the index TB guidelines. Moving on to abdominal tuberculosis. Ileocecal region is the most common site for the general surgery residents. So you need to look at the intestinal, peritoneal, mesenteric lymph nodes, solid organ TB. So almost everything is involved. And diagnosis classically, wherever the patient presents with, like 35-year-old presenting with abdominal pain, weight loss, ascites. So if the CT abdomen shows thickened ileocecal region, necrotic mesenteric lymph nodes, it's a classical description for tuberculosis. So diagnosis, ascitic fluid analysis. So you all know the ascitic fluid, serum ascites albumin gradient. This is SAG. So serum ascites albumin gradient, if it is less than 1.1 gram per dl, so it is a classical description for tuberculosis. If it is more, that will point towards portal hypertension, especially cirrhosis. And high protein, again lymphocytic predominant, all these are common. ADA is greater than 39. So you need to remember ascitic fluid, ADA greater than 39, high protein, lymphocytic predominant, and SAG less than 1.1 gram per dl. So this is the classical description for tuberculosis. So one is ascitic fluid, and the next things, if you want a definitive diagnosis, you need to look at peritoneal biopsy or endoscopic biopsy for in case of liver biopsy in case of solid organ involvement, ileocolonoscopy when the ileocecal junction is involved. So culture is another thing when you look at, and one important point here is, rather than taking a small sample of ascitic fluid, it's better to take a more sample, like the ways like the things we send the cell block for malignancy. Here also, if you centrifuge and send a more sample, it is the sensitivity increases to 83%. So chronic abdominal symptoms, persistent abdominal pain, abdominal distension, diarrhea, constipation, vomiting, and with constitutional symptoms. And whenever there is subacute intestinal obstruction, and doughy abdomen is nothing but whenever there is omental involvement and omental caking, it will give a feel of a dough. And mesenteric lymphadenopathy again, and hepatosplenomegaly, especially PUO, pyrexia of unknown origin with abdominal symptoms. Always suspect tuberculosis. So treatment is 2 plus 4, HRJD plus HRE. So genitourinary tuberculosis. Kidneys are the most common site to be involved, and classical feature here is sterile pyuria, which means pustules are present in your CUE, whereas cultures are negative. So I'm just going very brief about it. Genital, usually epididymis in male, and fallopian tubes in female are the most common sites. So presumptive urinary TB. So what the guidelines say is, in case any patient presents with LRTI, symptoms of lower urinary tract symptoms, frequency, urgency, nocturia associated with dysuria or hematuria for at least 2 weeks, and they are not responding to antibiotics, especially if they have constitutional symptoms, always think of tuberculosis. And female genital, if a premenopausal woman presenting with infertility, menstrual problems, unexplained abdominal pain or pelvic mass with constitutional symptoms, always think of tuberculosis. And even male genital, if there is a scrotal swelling for more than 2 weeks, not responding to antibiotics, and if there is a discharging sinus with systemic symptoms, always suspect tuberculosis. So diagnosis, if there is hematuria, sterile pyuria, microscopic hematuria in greater than 90% of the cases. So here it was already dealt. Urine for AFB, minimum 3 samples. Here 3 a.m. to 6 a.m. early morning samples, minimum 3 samples should be given. And your PCR is 90% sensitive. And in this case, actually AFB is not preferred. And other modalities or pelvic ultrasound, hysterosalpingogram, and you can do a hysteroscopic biopsy, or you can do an endometrial aspirate and send for cultures. And then for scrotal swelling, you will ultrasound scrotum. If there is an epididymal mass, then FNAC epididymal mass. And next is biopsy of any tissue specimen. So 60-year sterile pyuria burning micturition gold standard is culture of mycobacterial tuberculosis from urine or tissue samples. So it's the same, I'm just rushing on. So treatment is HRID plus HRE 2+4, it's the same. Pericardial tuberculosis, infection of the pericardium. So usually here there will be pericardial effusion. So signs of pericardial effusion for the general medicine residents. So you will be hearing distant heart sounds, raised JVP, all these are right heart failure. So signs of right heart failure. So raised JVP and also hypotension. So echocardiogram is the gold standard. So your 55-year-old male presented with progressive breathlessness since 15 days and pedal edema, fever, etc. If the echo is showing pericardial effusion, then think in terms of TB pericarditis. So presumptive TB pericarditis with the constitutional symptoms, and if there is evidence of pericardial effusion or constriction on chest X-ray, ECG or echo, it's definitive TB pericarditis. So ECG, echo, elevated cardiac enzymes, pericardial fluid analysis, again lymphocytic predominant. In HIV, sometimes there will be decrease in lymphocytes, and PCR only, it is more specific than sensitive. Here pericardial fluid ADA cutoff is 30 units, and biopsy there is more than 3 weeks of illness. So constitutional symptoms, chest pain, breathlessness, hypotension, raised JVP, pedal edema, ascites, hepatomegaly, and if there is a large pericardial effusion. So without any obvious cause, then think in line of TB pericarditis. Treatment is 2+4, HRID plus HRD. So we have last 2 specialties here. Dermat. How many of you are dermat residents? 1, 2, 3, 4, 5. Okay. So I'm not going into the details. This is just a brush off. Like if there is infection of the skin by Mycobacterium tuberculosis, so that is cutaneous tuberculosis. So we have 2 types here. Actually, if there is direct infection to the skin, where you call it as true cutaneous tuberculosis, or sometimes there will be an immune response to the tuberculous bacilli, where you call them as tuberculates. Okay, so your true cutaneous tuberculosis will be like lupus vulgaris, which is one of them most common, and scrofulodoma or tuberculous varicosa cutis, and tuberculates where the bacilli are absent. It's pure hypersensitivity reaction. Erythema nodosum, papillonecrotic tuberculates, all these come under the types of cutaneous TB. So direct and immune response. Classical, you will see a chronic progressive reddish brown plaques on the skin. So skin biopsy will be showing granuloma. Anywhere biopsy HPE, just remember if the description is granulomatous inflammation with caseous necrosis with Langerhans giant cells and epithelioid cells, it's always a classical description on HPE for tuberculosis. Okay, so it's like 32-year-old male farmer slowly enlarging painless reddish papule with again constitutional symptoms, low grade evening rise of temperature, weight loss, fatigue for the past 3 months, and if there are ulcers, discharging sinuses, and persistent asymptomatic raised reddish brown skin lesion, especially more than 6 months duration, always think in line of tuberculosis. So it's again cultures, CBNAT, skin biopsy, and as I told you, tuberculosis it's always an immune response to tuberculosis. So here your MAN2, tuberculin skin test, has a major role. If there is strong positivity greater than 22 mm in duration, it is suggestive. And IGRA again, and which was already dead. So if painless reddish papule, no previous treatment except topical antibiotics, family history of pulmonary tuberculosis, single plague on skin, irregular shape, reddish brown, and if on diascopy, if the lesion shows apple jelly nodules. It's a classical description for tuberculosis. Treatment is 2+4, HRJD plus HRE. And last two, ocular tuberculosis, ophthalm, anybody from the ophthalm? Okay. So in ophthalm, like even in the eye, any part can be involved, right from you can have uveitis to choroiditis to retinochoroiditis, everything. If there are systemic manifestations, and if you have uveitis, and only problem here is there is limitation in sampling. So we can't just go biopsy everywhere in the eye, which will actually lead to visual impairment. So you should be very careful about it. So one limitation we have here is ocular sampling. So diagnosis, you can do a MAN2, IGRA, ACE. Why is ACE important here is tuberculosis, one of the major differential diagnoses for tuberculosis is sarcoidosis. And sarcoidosis, again ocular manifestations in sarcoidosis are very common. So your angiotensin convertase enzyme levels are very important here to differentiate between the tuberculosis and the sarcoidosis. So cultures, again, vitreous fluid also is helpful, but it is not actually more sensitive to get the tuberculosis test positive. And ocular imaging, all your graphies which come into place, I am not going into the details. And biopsy from the retinochoroidal if you have any mass or something. And treatment is 2+4. It can be extended up to 9 months as per the index TB guidelines. And ENT laryngeal, ENT residents, anyone? 2, 3, 4, 5. Okay. So laryngeal, ear, oral, oropharyngeal, sinonasal. So everything in your scope is involved. And here, if there is one more thing, here you can go for a punch biopsy. So if there is any vocal cord nodule or etc., you can go for punch biopsy, AFB staining, and you can send it for HP or cultures. FNAC, whenever there is any lymph node involvement along with that. And treatment is 2+4. Again, it can be extended to 9 months based on the clinical scenarios. So this is almost, I am done. Just 2 minutes. So we are done with the treatment. Only thing, just a note on steroids. So steroids role actually we only use in certain situations. It's not at every tuberculosis, and especially steroids are used only as an adjuvant to anti-tubercular treatment. So CNS TB is one indication, tuberculous meningitis, tuberculoma, where it acts to decrease the inflammation in the edema and also the neurological sequelae. And pericardial TB is one where it decreases the risk of constrictive pericarditis. And one more thing is when there is pleural tuberculosis, that too when massive, not responding, and abdominal tuberculosis, whenever there are only adhesions or severe inflammation, then there is a role for steroid therapy. Genitourinary tuberculosis used to reduce fibrosis, strictures, not routinely used for any other lymph node or spinal, etc. The major thing you need to look at is anti-tubercular treatment. So, what is the take home? I hope I finished so many things in a very short time, and so I'm not sure. So, extrapulmonary tuberculosis is very important. So, tuberculosis per se, on the outside perspective, always people think in terms of cough. So, not all tuberculosis presents with cough. We have so many things, and almost every organ involved in the body with tuberculosis. And second important thing, as I explained through all the symptoms, when to suspect, etc. So if there is chronic unexplained symptoms, symptoms in endemic countries like India. So always think in line of tuberculosis. Wherever, be it abdomen, be it PUO, be it genitourinary, if the female is presenting with infertility, any which ways, you should always think in line of tuberculosis. Ours is an endemic country. And very important is strong clinical suspicion. So first thing, strong clinical suspicion is very important. Extrapulmonary tuberculosis is a paucibacillary tuberculosis. It's not all the times you get diagnosis through microscopy or microbiology. So it is a paucibacillary tuberculosis. So you should have strong clinical suspicion, and then microbiology and HPE, which is the key for the diagnosis. So thank you. My postgraduate, just 5 minutes, my postgraduate will ask you 10 MCQs. Whoever answers from the different residents, you will get chocolates. That's it. Thank you.
Moving on to the quiz. The first question, most common site of extrapulmonary TB is?
Note.
Anyone?
General surgery, residents.
You can raise your hands. Correct answer.
Hey, can you please get us? ఇప్పుడు కాదు ఆన్సర్ చేసేటప్పుడు లేకపోతే అట్లీస్ట్ క్వశ్చన్ అడిగిన ఆన్సర్ చెప్తారని తెలుస్తుంది కదా.
Moving on to the second question. Most common form of abdominal TB involves?
Okay, there on the back ileocecal.
Yes, correct. Our third question. Sterile pyuria is classically seen in?
Exactly.
One person.
We only have few chocolates. Okay.
Correct.
Actually, I wanted to give chocolates, so that's why I put only questions from the slide.
Most common complication of spinal TB? Ortho-PGs.
Ortho residents, anybody? No ortho residents. Okay. Anybody who wants chocolate?
Last.
Kyphosis.
Correct.
Okay.
Dowy abdomen is characteristic of?
Why?
One person.
One of you. Anybody get up an answer? Peritoneal.
Correct answer.
Yes.
Next question. ADA is most useful in diagnosis of?
One person. One person.
One person.
One person.
Yes, correct answer.
No, who answered TB meningitis? There CSF is the thing, not in the CSF. ADA will be there, but in pleural tuberculosis is more sensitive. Okay.
Our next question. Most common presentation of female genital TB? One person. Any gynec PGs?
Any gynec?
I heard the right answer.
Infertility.
Yes, correct.
Yes.
Cold abscess is seen in? Yes, correct answer. Can you please stand up?
Hey, no double answers.
Pied stem ureter is seen in?
Ureter, obviously.
Yes, tell. Yes, correct answer. Our last question. Ascitic fluid in abdominal TB is?
Very good.
Correct answer.
And these are the pulmonary vibes and PG.
అవునప్పి వారం కాదు వారాలు అవుతుంది, మందు వేసుకున్నా తగ్గట్లేదు.
మాడే మందు కాదురా, దగ్గు వరకు వేసుకోవాలి. అలా కాదురా, 2 వారాలు పని అంటున్నావు కదా, టీవీ పని చేయించుకోవాలి. హెల్త్ వర్కర్ కూడా చెప్పాడు మొన్న, 2 వారాల పైన దగ్గు ఉంటే టీవీ పని చేయించుకోవడం మంచిదని. టీవీ ఎందుకు వస్తుంది? అయినా మన ఇంట్లో ఎవరికి లేదు దానికి.
చాచా, నాకెందుకు వచ్చిందిరా టీవీ?
టీవీ రావడానికి చాలా కారణాలు ఉంటాయిరా, ఇంకేదో మంచిది చేయించుకో ఒకసారి.
ఇప్పుడు మీ ఇద్దరికి సమ్మగా ఉందా మొత్తానికి?
Okay. Here, this skit was played by our senior PGs who has already graduated. Just what they are trying to say. Anything. Yeah. One thing is here we are coming to know it's a TB stigma is there still present in the society. When we are start treating, we will have to encounter the stigma, because when we say it's a TB, suddenly they'll say that nobody in our family, it is not there and all. But TB basically it is there in the air. We can get infected at any time, any moment, any person. It doesn't even depend upon the socio-economic status. So whoever is having a cough more than 2 weeks, they have to encounter. Do you think that easy? Are they advising them right? One person is advising them to go to the TB for diagnosis and the other person is saying no. For whom do you vote? The blue shirt is saying that you have to go. The other person is saying don't go. Who will vote for the a blue color shirt? I want all the hands to be raised. Yeah, we have to go for the diagnosis. We have to go. There is no other option.
సరే, ఎట్టా దగ్గు తగ్గట్లేదుగా, ఒకసారి చూపించుకుంటాలే. రేపు ఒకసారి హాస్పిటల్కి వెళ్దాం, దగ్గు తగ్గట్లేదు.
సచ్చినాడు అడ్డమే తిరిగి ఏమేమో అంటించుకున్నావా? ఎందుకు? ఏదైనా మందు తాగు, అదే తగ్గుద్ది. హాస్పిటల్ అనుకో, ఆ పరీక్ష చేసుకోండి, అడ్మిషన్ అవ్వండి అంటూ అడ్డమైన ఖర్చులని చేయిస్తారు. రోజువారి కూలికి వెళ్ళేటోడికి డబ్బులు ఆడేస్తాయి అనుకుంటున్నావు?
అలా కాదు, మరి రేపు వెళ్దాం ఒకసారి. దగ్గు ముందు కూడా వాడాను, తగ్గట్లేదు. మన సూర్యగాడు కూడా అదే చెప్పాడు.
వాడికే 1,00,000 చెప్తాడు. నీకేమైనా అయిందనుకో, మొదట వాడే నీతో మాట్లాడడం మానేస్తాడు. ఎందుకు?
ఇప్పుడు ఒకసారి చేయించుకోలేదు అనుకో, అది ముదిరి నీ మనసాన్ని పడితే ఏం చేద్దాం?
అది చేసుకో. నువ్వు డబ్బులు గుల్ల వేసేవరకు నీ మనకి శాంతి పడదు. ఏమన్నా వేసుకో, నా మాట ఏ రోజు తిన్నావు కానీ.
వెళ్దామా ఒకసారి?
సరే, నీ చావు చదువుకో.
Yeah. Here, whenever the patient, sometimes before going to the hospital, definitely they'll think about the money. That is the reason the government is providing. The TB patient should not spend even a penny for their, neither on the treatment nor the diagnosis. Everything is free. This we have to take to the society, that the treatment, diagnosis, everything is free.
నమస్కారం డాక్టర్. 2 వారాల నుంచి దగ్గు వస్తుంది, ఏ మందులు వేసుకున్నా తగ్గట్లేదు డాక్టర్.
చెప్పానా ఈ డాక్టర్ నిన్ననే పరీక్ష చేస్తారు, డాక్టర్ మేము పరీక్ష చేయించుకోము. ఈ పరీక్ష చేసేది కదా కావాలని మంచిది తగ్గుతుంది ఇవ్వండి.
నువ్వు ఆత్మ ఎందుకైనా మంచిది చేయించుకోమని ఇంట్లో అసలు తాతయ్య అమ్మ ఉన్నారు. మీరేం అనుకోకుండా డాక్టర్, మా అమ్మ కంగారు మాట్లాడతాం. సరే డాక్టర్, మీరు చెప్పారుగా చేయించుకుంటాను.
Here, 2 things. Whenever we are asking the patient to get test, one thing is we have to inform that, yeah, you have to get tested for yourself to get cured, and also to prevent the spread. If you are leaving a TB patient without testing, he is going to infect few more people. So always, if you want to control, and if you want to control the TB, yeah, eradication is our aim. But before going that, if you want to end the TB here, or if you want to go ahead towards that, first initially we have to tell them that it is not only for you. To protect your friends, near and dear ones, you have to get tested. So the counseling plays a major role whenever you are asking a patient to get tested, to go for the TB treatment and all.
నమస్కారం అండి. డాక్టర్ గారు మీ దగ్గరికి వెళ్ళి సర్టిఫికేట్ పరీక్ష చేయమన్నారు.
ఇప్పుడు నేను మీకు 2 డబ్బాలు ఇస్తాను. ఒక డబ్బాలో ఇప్పుడు కప్పం పట్టేవ్వండి, ఇంకో డబ్బాలో రేపు ఉదయం వస్తా కప్పం పట్టి తీసుకురండి. ఎన్నిసార్లు రావాలి, ఎన్ని పరీక్షలు చేయించాలి? రిపోర్ట్లు తీసుకోవడానికి అయితే ఖచ్చితంగా ఒకసారి రావాల్సి ఉందమ్మా.
సరే అండి.
Yeah, now we don't have to go for the 2 samples. 1 sample is enough. TB CB-NAT, you will get a diagnosis and the resistance within 2 hours. The CB-NAT is replaced by TrueNAT, which is an Indian made. Definitely Indian government is working towards that eradication, as it is providing everything to the, we are having a TrueNAT machine Indian made.
ఏమైందిరా?
ఏం లేదురా, రేపు కానీ నీ పరీక్షలో టీబీ తేలాలా ఎలా అని ఆలోచిస్తున్నా. మనతోటి ఒవ్వరు మాట్లాడాడు, ఇంటికి ఒవ్వడు రాడు. ఈ సమాజం ఎలా బతుకుతాం అనుకుంటాము?
నువ్వేం భయపడకు, ఏం కాదు, గమ్ముగా ఉండు. నేను అలా బయటికి వెళ్ళి వస్తానులే.
తిరిగి ఇంకా 2 రోజులు ఎక్కువ తెచ్చుకొని రా.
ఎక్కడికి వెళ్ళండి, మా సూర్యగాడి ఇంటికి.
వాడితో వెళ్ళి గొయ్యిలో చదువుకో. ఇంకేం చేస్తావు, నా మాట ఏడో తిన్నావు కానీ.
నమస్కారం అండి.
నమస్కారం అండి. మీకు కళ్ళ పరీక్షలో టీబీ ఉందని తేలింది. మందులు పెడదాం.
ఇప్పుడు టీబీ వచ్చిందండి, ప్రాణానికి ఏదైనా ప్రమాదం అండి?
ప్రాణానికి ఏం ప్రమాదం లేదండి. టీబీ మందులు 6 నెలలు క్రమం తప్పకుండా వేసుకుంటే సరిపోయింది. మధ్యలో మానేసిన గుండెలకు టీబీ వచ్చే ప్రమాదం ఉంది. ఆహారం కూడా బాగా తీసుకోవాలి.
6 నెలలా? ఇప్పుడు ఈ డబ్బులు ఖర్చు అయితే చాలా పుల్లైనట్టే. మేము అసలే మా ఊళ్ళో మల్లిగాడు ఇట్లనే మందుల కోసం అని పొలం కూడా అమ్ముకున్నాడు.
అవసరం లేదమ్మా, టీబీ మందులు ఉచితంగా గవర్నమెంట్లోనే ఇస్తుంది. తెలియక చాలా మంది బయట కొనుక్కుంటారు. మీ యొక్క ఆధార్, ఇంటి అడ్రస్, బ్యాంకు వివరాలు ఇస్తే గవర్నమెంట్ ప్రతి నెల 500 రూపాయలు మీ అకౌంట్లోకి వేస్తుంది. ఆహార అవసరాల కోసం.
ఈ 500 ఎక్కడ సరిపోతాయి?
తప్పదమ్మా, ఖచ్చితంగా 6 నెలలు మందులు వాడాల్సిందే.
సరే కానీ ఈ మందుల కోసం ప్రతిసారి రావాలి ఇక్కడికి?
ఏం అవసరం లేదమ్మా, ప్రతి నెల మేమే మీ ఇంటికి వచ్చి మందులు ఇస్తాము. ఈ మందుల వెనకాల మీరు రోజు మందు వేసుకున్న తర్వాత దాని యొక్క నెంబర్కి ఫోన్ చేయాలి. అంతేకాకుండా ఈ మందులు వేసుకున్నప్పుడు మీకు కడుపు ఉబ్బరం, వాంతులు, దురద లాంటివి వస్తాయి. వెంటనే మీ యొక్క డాక్టర్ని సంప్రదించండి. అంతేగాని ఎప్పుడు పెట్టినప్పుడు మందులు మానేయండి.
సరే అండి.
ఇప్పుడు ఎలా 6 నెలలు పనికి వెళ్ళకపోతే మాకు డబ్బులు ఎలా వస్తాయి? అవసరం లేదమ్మా, 2 వారాల పాటు ఎవరిని కలవకుండా పనికాలం ఉంటే సరిపోయింది. మళ్ళీ కప్పం పరీక్ష కోసం 2 వారాల తర్వాత ఇక్కడికి రండి. ఒకవేళ దాంట్లో ఇంట్లో వస్తే పనికి వెళ్ళచ్చు.
పోనీలేమా, 2 వారాలే అన్నారు. ఆరోగ్యం కన్నా ఏమి ముఖ్యం కాదు.
సరే లేదండి, ఆ రోజు టీవీ కావాలి నాకు.
సరే అండి.
సరే అండి.
Yeah. Here, when the patient, whenever you're revealing that the patient is sputum positive, you have to make sure that if it is sputum positive, he will be infected till at least 2 weeks. He should isolate himself. So he should be like, you should have to write a letter to the wherever he's working, to the organizations and all, that he should take a leave for 2 weeks, so that the infectivity, at least we'll be saying 2 weeks, but at least 20 days where the highly infectivity it will come down till sputum becomes negative. And one more thing, whenever you are doing the counseling part plays a major role. You have to tell them that in between they should not stop the medicines. If they stop, it is going to, they'll come to us like an MDR TB. It is not only for them, it is going to, they are going to, if MDR is going to come, whenever they infect others, it will become, they will be infecting others also with MDR. So we have to do counseling in a proper way with all the side effects. You have to inform them. If they have side effects or anything, they have to consult a doctor not to stop medicines in between to prevent the MDR tuberculosis. And the other thing is, to get a proper treatment, first thing is he will be treated, and the second thing is he should not spread TB to other people. So there it starts, like our counseling plays a major role. Don't just write the treatment, don't just do send the treatment to write name, oh you have to get treated. It is not like other drugs. They have to get a prolonged treatment. You have to say what is the importance of that before starting on tuberculosis drugs.
ఊరమ్మడు ఫస్ట్ సాయి గారు మేము అన్నడికి ఊరమ్మడు తిరిగి టీవీ తెస్తున్నాడు కొంచెం 2 వారాల నుంచి దూరం ఉంటే మనందరికీ మంచిది.
Maybe the way she told is rude, but that is what is mandatory. Elderly people and the pediatric age group, they should be away from the Spoda positive patients.
మీ హ్యాండ్ కాదురా టీవీ పాజిటివ్ వచ్చింది చూడు. ఇప్పుడు నాతో ఎవరు మాట్లాడరేమో, ఏమనుకుంటారో, మా ఇంటికి కూడా రావడం మానేస్తారేమో.
ఏదైనా సాయం కావాలంటే మమ్మల్ని అడగడం మంచి చూసుకుంటాం.
నాకు అదే ధైర్యం రా, మీ ఇద్దరు ఉన్నారు రా నాకు. నమస్కారం డాక్టర్. మందులన్నీ పూర్తిగా వాడా డాక్టర్?
మళ్ళా పరీక్ష అంటే అనవసరంగా డబ్బు ఖర్చు.
నువ్వు అలాగమ్మా ఎప్పుడు డబ్బులు అంటావా? పోదా తీసుకురావా? మీరు చెప్పారు కదా చేసుకుంటారు సార్. ఇదిగో డాక్టర్ రిపోర్ట్లు వచ్చినాయి. పూర్తిగా నయం అయిపోయింది డాక్టర్. మరి ఇప్పుడు పెళ్లి చేసుకోవచ్చా? అట్లా మాట్లాడతారే సార్, మీరు నాకు దేవుడు నాన్న మిమ్మల్ని తెలవకుండా ఉంటానా? సరే డాక్టర్.
Yeah, this is like, it is once you diagnose the tuberculosis, they feel that as if it is a malignancy. Oh, can be cured or not? So we have to give assurance once if you take the proper treatment, it is completely cured. But they have to go with the treatment properly. We should have a proper follow-up and all. Thank you for patient listening. Thank you very much.
With this, we come to the end of today's session. I thank everyone, especially our faculty members, for enlightening us, and to all the postgraduates for being active participants here. Thank you. And I request all the first year postgraduates to be back here by 2 o'clock for orientation program.